For all your questions. Today in the Instagram Live, I'm going to answer some of your questions. I asked this morning for questions about HRT, doses, types. There always is a lot of confusion about dosing and types of HRT. Now, as I've told you before, HRT is just 3 letters, hormone replacement therapy. It's not always replacing. When we start hormones in the perimenopause, we're just topping up what's missing. So we just talk about the 3 hormones, estradiol, and I say estradiol because that's the beneficial type of estrogen, progesterone and testosterone. They're 3 hormones. They're actually, progesterone forms estradiol and testosterone. So progesterone, some might think, is the most important hormone, and they're derived from cholesterol actually. So cholesterol is actually really important for us, and there's lots of enzymes and pathways where cholesterol forms progesterone, progesterone breaks down to testosterone, and testosterone is aromatase to estradiol. So they're 3 separate hormones. They work closely together, but they are different. And we have receptors for estradiol, progesterone, testosterone throughout our body. In fact, on every single cell in our body. They're just natural hormones that have biological effects. And as some of you might have seen, my post this morning was talking about the anti-inflammatory effects of hormones. And that's important when we think about reducing risk of diseases. So the reason that we give hormones to people are twofold. Firstly, to improve symptoms, but secondly, to reduce risk of future diseases. And that is important because we're living longer. So we are living longer, but actually many women live the latter part of their life in poor health. There's lots of reasons why that can occur, but some of it is related to it not having hormones, because once we're menopausal, we're always menopausal. Our hormones will always be low unless we replace them by taking HRT. So I've had lots of questions, so I've got them on my computer here, so I'm just going to do as I did before and answer them. In my mind, as a physician, as a menopause expert, the most important thing is for women to have the right dose, the right type of hormones at the right time for them. And it's really important, all those things, because we're all different. The way we give hormones can vary. The way we absorb the hormones through our skin, if we're having it through the skin, can vary. The way we metabolize those hormones, the way we use them. It's always different, and often dose needs to change with time. It might need to be increased if people start during the perimenopause and then their own hormones decline further, or they might need to reduce with time, because sometimes we give a higher dose to stop the fluctuation in the perimenopause, and as people's own hormones reduce, then we reduce hormones. The dose of estradiol, progesterone, testosterone can vary independently as well. So it's very important that we're all seen as individuals and managed as individuals as well. So I'm going to stop talking and answer as many questions as possible. So this lady says, I've got no ovaries in uterus for the last 3 months. Do I need more estrogen? I'm on a 75 microgram patch. Impossible to answer, obviously, individual advice here, but often in the clinic we do estradiol levels, and that will give us a guide how people are absorbing the estrogen through the skin. If the level is low and you're still experiencing symptoms, then it is worth considering increasing the dose, just because you want to have enough estradiol in your body for those health benefits. So to reduce risk of heart disease, osteoporosis, diabetes and so forth. It all depends on how you're feeling. It sounds like you've had a surgical menopause because you've got no ovaries or womb, but it is also worth considering, maybe, depending on your symptoms, testosterone and progesterone. As I've said before, progesterone does more than just protect the lining of the womb. I've been on HRT, estrogen and testosterone for almost 10 months, but still get low mood. Now, there's lots of reasons why people can get low mood. Of course, it's not all related to hormones, but it is worth having your hormone levels done. We often do estradiol, testosterone and SHBG, which is sex hormone binding globulin, to see how the levels are. And if they're low, then it might be increasing the doses of either. Also thinking about progesterone if you're not on progesterone. Some women have clinical depression or, like I say, other reasons for low mood. So it's important not to avoid other treatments if you need them, and they can be taken with HRT. Marina coil and Utrogestan, is that okay? Yes, increasingly we give both actually. The Marina is very good for the lining of the womb. It works locally, but it's a synthetic progestogen. It won't have the beneficial effects of progesterone throughout the body, so you can use both. Is Lenzetto spray and Utrogestan a strong type of HRT, or what would be stronger? Depends what you mean by strong. Lenzetto is a spray, but actually in our clinical practice we tend not to use it very much because we just find that it doesn't get absorbed very well. It's very unreliable actually, the way it's absorbed into the body. It's supposed to be applied on the inner arm and then it just gets absorbed very slowly. But when we started using it when it first came out over to the UK, we just found that it was really quite taking a long time to be absorbed, and then a lot of people found that they were still having symptoms, their estradiol levels were really low. So I tend not to use it actually. We just convert people to the gel or a patch. I'm on continuous daily Utrogestan vaginally. Is that too much? It really varies. So we can give Utrogestan off license as a vaginal pessary because it's like a gel. The outside melts off often in the warmth of the vagina. Then it gets absorbed through the vaginal mucous membrane into the bloodstream. The dose really varies for women. Some women, especially women who've had PMDD or PMS, premenstrual syndrome, might find they respond better with more. But often if people need more, we use Cyclogest, which is a pure progesterone pessary, which is made for the vagina, or it can be used rectally, and they come as 200 or 400 milligram pessaries. So it really does vary, but if you feel you need more or a different dose, then you should speak to someone who understands. My symptoms indicate to me that I need testosterone. How do I persuade my GP? If you're in the UK, it really varies, and actually globally it really varies as well. Testosterone isn't licensed for women. It's licensed for women in Australia, but not in other countries, but we can prescribe off license the male testosterone at lower doses obviously than what men need. It can be used for reduced libido. We know it improves libido, but it actually we know that it works throughout our body and our brain as well, so it can improve mood, energy, concentration, stamina. A lot of people find that sleep, muscle and joint pain improve as well. So it's about trying it and seeing if your level is low and you feel you might have symptoms related to testosterone deficiency. It's certainly worth exploring with your doctor and asking if you can try for 3 to 6 months to see if it improves the symptoms that you're having. Some people come and see us for testosterone in the clinic, and then once people feel better, then it's easier then often to ask your GP going forwards, and often GPs take on prescribing once you've started it with us. Where is the correct place to put HRT patches, please? So the way it's been licensed is below the waist, and that just means that's the way that it was tested. It doesn't mean that the skin below your waist is any different to the skin above the waist. We're using the skin just as a vehicle to absorb the estrogen, the estradiol through the skin. Now the estradiol is in the glue where the patches stick. So it really varies, the absorption. So it all depends on the skin type, the temperature, what the blood vessels are like under the skin, and also the thickness of the skin, of course, or whether there's subcutaneous fat under the skin. So some people find it's better on their bottom or their lower back or their thigh. It really, really varies. If it's not sticking on very well, make sure the skin is really dry and clean, and then obviously apply it, put some warmth on, so because that heating up the glue can help it stick. But if it's really not sticking very well and you're not improving, then it's worth trying another type of patch or even at the gel. I'm on 2 pumps of estrogel, 1 progesterone, still have anxiety and low mood. Should I up estrogel dose? Again, it's really individual. Like I say, if someone like that was seen in our clinic, we often do an estradiol level, and if it's low, then we can consider increasing the dose. But then if a low mood can be associated with other things, also, like I say, thinking about testosterone as well. Do you always need testosterone, and how do you know if you need it? Of course, no one always needs anything. It's an individual choice. The most important thing, I think, in menopause consultations is that patients are central. We can decide as patients what is best for us once we have knowledge and we speak to someone who can share that decision making with us. Increasingly, I liaise with a lot of global experts, especially in America, who are very confident in prescribing testosterone, and a lot of doctors and nurses and pharmacists I speak to, like us, really notice that these other symptoms improve. So it's a very safe hormone. Most people don't get side effects at all. So often trying testosterone and see if it helps is actually not very risky compared to other things that we often prescribe for low mood. We see a lot of women who've been given and prescribed antidepressants which have more risks than testosterone. I don't always absorb patches or gel. What's my alternative? So it's really difficult. Some of you might know I don't absorb very well, but I do use more than one patch. I find that the gel really just floats off my skin, and the other type of patch that I use just ended up like in my jeans. It didn't stick on very well. So I just find using more than one patch actually means that I absorb enough through my body. My levels have never been raised. They're just within a normal level, but if I only use one patch, my levels are low and I get dreadful symptoms. Some people use a combination, so they might use patches and gel, for example. Some people use tablets. Now, estradiol tablets may or may not be related with a small risk of clot. Some studies have shown they are, but some studies have shown it's the synthetic, the conjugated equine estrogens, the pregnant horse's urine, that is associated with the story. So certainly the synthetic progestogens do have a small risk of clot associated with them. So you have to be careful if you've got a history of clot, a family history of clot, increased risk factors. If you have migraine, then oral estrogen probably isn't for you. So it's just trying to phone me. The other thing is implants. We don't use implants in our clinic. We do refer some people for implants. Often though, with implants, it's very hard to monitor or to get the dose exactly right because of the way it's absorbed. So a lot of people actually get very high levels of estradiol when they have implants, but some people do use them. Like I say, some people do use the spray with good effect, but it's just working out a combination that's right with you. What is the difference between estrone and estradiol? So estrone is a type of estrogen that is converted when people have tablet estrogen. So when we have anything through our mouth, it gets metabolized in our liver. Our liver breaks down estrogen to different types, and estrone is one type of estrogen. We also produce estrone in our fat cells. So our adipocytes produce all sorts of chemicals, all sorts of hormones, including estrone. And many people put on weight when they're menopausal without hormones because their body's trying to produce estrogen. Estrone is more inflammatory. It's actually a pro-inflammatory type of hormone, and it's been associated with risks actually, especially there's a few studies showing that the risk of breast cancer is with estrone, not with estradiol. So that's why we prefer to give estradiol through the skin as the patch or gel, because it gets absorbed as the pure estradiol. What is the advice in regards to long COVID and hormones? Well, I've spoken before about long COVID, and we've got information about it on our website. The symptoms of long COVID, perimenopause, menopause are very, very similar. I think there's a big overlap. Some women are being diagnosed with long COVID and no one's rebalancing their hormones. I am not saying long COVID is all due to low hormones, but I am saying it's worth considering having hormones rebalancing. A lot of women we see with long COVID have very low testosterone levels as well. Is it okay to split my 2 doses of estrogen to morning and late afternoon, or have 3 doses? Absolutely. A lot of people find that they have a peak when they have the estrogen gel, and then it declines with time, and so the decline can sort of really reduce over about 18 hours or so. So usually I recommend that people divide it so they have it morning and evening. Some people are very sensitive to just small changes of estradiol in their body, and so I have some patients who just use a small amount 3 or 4 times a day. It's absolutely fine. Whatever works for you is usually best. Can adding testosterone help increase estradiol levels? because testosterone converts to estradiol, there's always people talk about there's some aromatization of the testosterone increasing estradiol. I don't really see it much in my clinical practice actually. When people are started on testosterone, we do their testosterone and estradiol levels a few months later. I don't really see a big increase in estradiol actually, so I think it's more of a theoretical thing. Perimenopausal symptoms but still having periods, is contraception better than HRT? Now, practice really varies actually, and some countries the doctors seem to recommend contraception first. Now, the thing is about HRT is it's not contraceptive because the dose is very low, but the hormones are completely natural. That means they're the same structure, the same physiological and biochemical structure as our own hormones, which means they have the same benefits. They have these anti-inflammatory benefits. They improve symptoms. We know that the risks, for example, of stroke and heart attacks and clot and even breast cancer are with the synthetic hormones. So that includes contraception. Contraceptives are a higher equivalent dose as well. We have less good safety data on them as well. So in my mind, if you're going to be starting hormones, unless you really need contraception, you're better off going on the natural hormones because there's less risk. You can control the dose. Contraceptives are fixed, so therefore they're estrogen and progesterone together. But both the estrogen and the progesterone are synthetic, chemically altered. And so if you need to increase just if you just want to increase the estrogen and not increase the progesterone, you can't do that with contraception. You have to do them both together. So there's less fluidity really. It's more fixed. The other thing about the combined oral contraceptive pill is that it will increase sex hormone binding globulin, so reduce really available testosterone. So if your testosterone level's a bit low, it will be even lower when you start the contraceptive pill, which may cause some symptoms of testosterone deficiency. Since increasing my estradiol to 4 pumps a day, I'm actually losing weight. Well, that's because your body won't be making estrone, so it won't be producing as many fat cells. Also, estradiol helps our metabolism, so do the other hormones as well. So it means our metabolic rate is better. A lot of people find also that it's easier to sleep, it's easier to exercise. So our sugar control improves, our pancreas works better when we have estradiol in our bodies as well. So that's another reason having the right dose is really important to reduce inflammation in our body. Our Everol Conti patch is okay as it has synthetic progesterone. Would micronized progesterone be better? It probably would. The Conti bit is the synthetic progesterone. It's only a low dose absorbed through the skin, but it probably still has the same risk, the small risk of clot and stroke and heart attacks. It's only a small risk, but I always think in medicine, if you can get away with not having a risk at all, isn't that better? So micronized progesterone is safer on those accounts, and you can get the pure Everol patches with the micronized progesterone. I take Bijuve capsules as I wasn't absorbing Everol. So can I take two? So Bijuve or Bijuva in the US is a very low dose. So it's got 1 milligram of estradiol, 100 milligrams of utrogestan. It's a fixed dose preparation. The studies on it actually have shown that there isn't a risk of clot with this preparation, but the dose of estradiol is quite low. If you need more, you might not necessarily need more of both. You might need more of maybe the progesterone, or you might need more of the estrogen. It's not licensed to have two, but some people do benefit from two, which would be 2 milligrams of estradiol and 200 of utrogestan. But it's worth talking to a menopause specialist about that because there are other options as well. Progesterone taking vaginally still helps rest of body as much as when taken orally. So there is a difference in that when it's used vaginally, it gets absorbed as the pure progesterone. When it gets absorbed or taken in orally, it gets metabolized to other progesterones as well. Some people find the side effect of sleep is more beneficial when people have it orally because it stimulates something called GABA, which helps us sleep. It's something in our brain, and that you don't get the same stimulation when you have it vaginally. But then some people find that they have less side effects when they use it vaginally, or they might feel more calm and less anxiety when they use it vaginally. It really, really varies. So that's why if one way doesn't suit you, then it doesn't mean you can't take progesterone. It might be using it in the other way instead. Progesterone, what does micronized mean? So micronized is just the way of having it available orally. When they discovered progesterone, it took a long time actually to find how to absorb it orally through into the body. So basically what they do is they micronize to make it very, very small, and then they suspend it in some oil, and then when that's taken in orally, it can get actually absorbed into the body. Is getting the balance of doses just trial and error? Yes, but with some, it is a bit of a craft as well. You know, in our clinic, we have a huge amount of clinical experience, and the knowledge that I've obtained from my patients over the last 8 years is phenomenal, because we collect all our data, because we're looking at levels, because we're looking at symptoms, we're monitoring all our patients who come to our clinic. We do a lot of clinical audit, we write up papers as well. Then we're really, really learning the craft of being able to individualise the dose and type for that person. Often it can be hard to know how people are going to absorb, how they're going to respond. So we spend a lot of time at the beginning really trying to optimise hormones to a physiological response. But seeing someone who really understands how to optimise hormones is really crucial. Oh, hang on, sorry. Let me just go to the next page. So many questions here. Sorry, I've had that already. Some of them are quite similar from before. Dose patch of 50 micrograms. If I swap to the gel, what is the equivalent dose? Well, again, it depends how you absorb. So if you don't absorb 50 very well, you might find that you absorb the gel a lot better. So the dose equivalent is hard to determine. But as a general rule of thumb, 1 pump is similar to 25 microgram patches, so 2 pumps similar to 50 micrograms, 3 pumps 75 for 100. But it really, really varies, honestly. And some of you might have seen the paper that we had published this week, and it shows there was a real variety of absorption with people with different doses, with some women on a lower dose absorbing more than some people on a higher dose. But also when people change, we sometimes find that we give the same dose equivalent from a patch to a gel, but then their levels either increase or reduce depending on what the absorption is doing. We're all different, and that's what makes it interesting, isn't it? Does too much estrogen gel aggravate adenomyosis? It can really vary. So estrogen can stimulate the lining of the wound, it can stimulate adenomyosis, but often if you give sufficient progesterone, which is very anti-inflammatory, then it usually doesn't have that negative effect. I use a Vestin cream vaginally, presumably it's the same for both. Presumably it's safe for my partner if I have sex after using it. Now, any vaginal hormonal preparation, the dose is incredibly low. If somebody gets it either from having penetrative sex or oral sex, then it's going to be such a low dose. I mean, we usually say try and wait a few hours after using any vaginal preparations before having sex, but it's not going to do any undue harm. I've just had a full hysterectomy, 5 days post-op. What HRT should I expect? Well, before you have a hysterectomy, ideally you should be talking to your surgeon about HRT choices. Really important, but I know that doesn't always happen, and I have spoken before about surgical menopause. You can start the natural hormones straight away after your operation because there's no risk of clot. It's very different to the synthetic hormones and contraception. So any operation, there's a small risk of clot, but having natural hormones doesn't increase that risk. But it also will help with wound healing and often help you to feel better as well. So your doctor should be talking to you about taking hormones as soon as you've had the operation. Can something such as iron deficiency affect how HRT works? This is really interesting because our hormones, estradiol and testosterone, affect iron absorption. So we know that iron absorption is reduced when we don't have our hormones. So we see a lot of menopausal women with low ferritin, low iron, which improves when they have hormones. So it actually won't affect the way HRT works, but having HRT will often improve iron absorption and iron metabolism. Can I ask my GP to do blood tests to check my hormone levels? You can ask, it depends. Some GPs do the blood tests, others don't. There's just quite a lot of confusion out there. We find that estradiol levels can be very useful clinically. They have to be done in clinical context, and the same with testosterone levels. If a lady has a raised level, it doesn't necessarily mean that we need to reduce the dose or stop the dose, because it really varies. If someone's perimenopausal, they'll be producing their own hormones, so we often then repeat the level. The same with testosterone, the absorption can really vary. So if someone is feeling really well with no side effects and their level is slightly raised, then we usually just repeat the test rather than just stopping or reducing the testosterone. Estrogen and migraines. Should I do low dose? My gynecologist wants me to stop estrogen. Well, I've done a podcast recently about migraines. Migraines can improve with the right dose and type of hormones. A lot of people, including me, find that migraines really improve when you've got the right dose, and it can take a little time. You have to go quite slowly with people with migraine because you don't want to do a sudden change which could then trigger a migraine. But progesterone can help with migraines. Also testosterone in our clinical experience often can improve migraines as well. So making sure that you work closely with your clinician to get the right dose and type of hormone can be very beneficial for migraine sufferers. My GP put me on Femiston, but it does not help with bloating. Is there anything else I can try? So Femiston is a synthetic type of HRT. It contains estrogen with some synthetic progesterone. It doesn't seem to have the same risks when you look at breast cancer as the other synthetic types of progesterone, but it's still tablet, it's still absorbed, it's still metabolized to the other hormones as well. So if someone isn't having some side effects with Femiston, I would change to the natural estradiol, the natural progesterone and the natural testosterone if they need testosterone as well, and really individualise the dose. So the most important thing really from this Instagram Live is having the right dose and the right type of HRT. Now on the story, I'll post later tonight the paper that we had written. Our research team that I fund, led by Dr. Sarah Glynn and Dr. Dan Rosel, and the team, Amy and Amy, have worked incredibly hard looking at our data and looking at the estradiol doses and the absorption with estradiol levels, showing this huge variety. And in our clinic, it's about a quarter of patients that don't absorb very well, need a higher dose to have adequate absorption. A lot of patients we see are already on HRT. We obviously run a specialist clinic, so it's likely that proportion will be lower out in the community. But even so, there are more than a handful of people who are like me, who just don't absorb very well. And so we give a higher dose just to get enough absorbed through the skin. It's really important for our symptom control and future health that we receive the right dose and type of hormones. So seeing someone who really understands, who's got a huge amount of knowledge and clinical experience is crucially important. So make sure if you are seeing someone, they've got a lot of experience and they see a lot of patients. So I hope that's been useful. Countdown to Christmas is on if you're celebrating it. If you're not celebrating it, you'll still hopefully have a bit of a rest over the festive season. And I just hope you have some good quality time with friends and family and just feel loved and supported. It can be a very unusual and unsettling time over Christmas. I have lots of mixed emotions when it comes to Christmas, but it is a time to pause and reflect and think about all the great things that we're all doing, and certainly the community of you that are working together to help support each other and to support me as well in the work that I do. I'm very grateful for. So I just want to finish by saying thank you for everything that you've done, and and continue to do to help each other, so we have lots of knowledge and support and information, so we can help each other have very positive experiences of our perimenopause and menopause. So I hope that's been helpful, and I look forward to seeing you next week. Thank you.